Hello, this video is going to cover chapter 16. It's going to cover osteoporosis and then thyroid medication. So before we get into those, let's review a little bit of the endocrine system itself. So the endocrine system basically is an organ systems that release hormones into the body. What are hormones? Hormones are basically proteins that elicit responses in your body and help regulate body function. So insulin example is probably the most common hormone everyone can think of. The other thing you can think of is thyroid hormone, which we're going to talk about now. And also going to be your sex hormones such as estrogen or testosterone. Those are all hormones. So they're all basically proteins that are released by organs that are going to elicit some response on the body. And it's when those hormones either get too elevated or too low, that's when we have problems. And we have to do hormone replacement. So we have to replace hormones that are missing to get back to normal body function. So there's several different glands and organs that release hormones in the body. The ones we're going to mainly talk about, we're going to talk about pancreas, which releases insulin. We'll get to that one in a little bit. Then also the thyroid, that's going to be a major one. Makes the thyroid hormone. That's important. We're also going to talk a little bit about calcitonin and parathyroid hormone, which helps with the absorption of calcium. That's where we get the osteoporosis from. So first, let's talk about the thyroid. There's three different thyroid hormones: T3, T4, and TSH. So T3 and T4 are your circulating thyroid hormones. They're what we think of as thyroid hormones, your T3 and T4. Their thyroid stimulating hormone TSH is released when thyroid hormone gets low. So basically, thyroid hormones T3, T4 get too low. TSH is going to be elevated because you're going to try to increase how much is circulating in the body to stimulate the growth, stimulate the thyroid to release more T3 and T4. If someone is, that person would be hypothyroid. Hypothyroid, low T3, low T4, high TSH. Hyperthyroid is where you have an abundance of thyroid hormones, so it'd be high T3, high T4, and low TSH. Because they're high, you don't need to stimulate the thyroid. So thyroid function is important for brain development function, heart and skeletal muscle contraction, breathing, oxygen use, and also it helps elicit other hormones in the body. So it's kind of important we have it regulated. So first, let's talk about hypothyroidism. So again, hypothyroidism is low thyroid hormones, low T3, low T4. So what we need to do is we're eventually going to need to give them synthetic hormones and bring it back up. So what will you see in your patient who's low hypothyroidism? Generally, the best thing to think about is everything is slowing down. Their body function, their metabolism, their heart rate. So basically you can see, we'll start off with fatigue. They'll be weak. They'll have cold intolerance. They'll be weak, tired. GI tract slowing down. They'll have constipation. They can see some edema from improper blood flow from the blood volumes. Decreased heart rate, blood pressure, temperature. Basically, everything is slowing down in the body. There's also a little box on page 293 in the 9th edition. You can read that. So how are we going to diagnose someone having hypothyroidism? Well, basically you're going to diagnose it by checking their thyroid hormones. Check their T3, check their T4, and their TSH. So ideally you would see in hypothyroidism, low T3, low T4, high TSH, because we're trying to stimulate our hormone and it's not working. So we're going to try to give them hormone replacement, which is going to be levothyroxine, is going to be the main one. We also kind of help with some of the other symptoms they have, and that would be in lines of proper diet, exercise, stool softeners, increasing fluids and fiber, and then trying to just keep them warm because everything's slowing down. So basically you want to try to stimulate the body, help things get going. On slide 10 is the drug for hypothyroidism. So it's levothyroxine sodium or Synthroid. Basically, this is a synthetic thyroid hormone agonist. So it acts the same as T3, T4, even though it's not. So it's an agonist, so it's going to bind to the receptors and elicit that positive response. So the thing to be aware of with this is a very long half-life, 6 to 7 days. So whenever a drug has a long half-life, you want to tell your patients not to double the dose if it's missed. If it's missed, it lasts for 6 to 7 days, they're fine, the medication is still going through their body. So we are treating hypothyroidism. So when treating hypothyroidism, you're going to end up causing hyperthyroidism for your side effects. Because you're treating hypo, so they're low. Now you give them more thyroid hormone, so it's going to go up. So in treating hypo, you end up going to cause potential side effects of hyperthyroidism. So because you have a low hormone, you replace it, you could end up potentially causing the opposite effect. From hypo, you end up getting hyper. So with that, you're going to see diarrhea, tachycardia, hypertension, insomnia, sweating, heat intolerance. Basically, everything that we talked about was a side effect of hypothyroidism. We're now going to cause the opposite. So some things to be aware of is you're going to potentially stress out the heart, causing heart failure, leading to chest pain. So if they have a history of MIs, hypertension, you want to caution. I also want to caution patients with epilepsy and with seizures. So you're going to want to monitor them for weight loss. You're going to monitor their anxiety. Are they able to sleep? What's their blood pressure? How's their heart rate? How are things going? So basically, everything's speeding up in the body. So you also want to look out for anticoagulants, NSAIDs, heparin, Coumadin. It's all going to lead to an increased risk for bleeding. And so beyond that, what are we going to do? So we need to reinforce that hormone therapy is a lifelong therapy because your organs and your glands aren't going to get better. They're constantly going to be low. So this will be a lifelong treatment. So we want to monitor their thyroid hormones. Monitor their T3, T4, and TSH. Are they all within normal ranges? If not, their dose is too low, you give them more, or it's too high, you need to give them less. The other thing to be aware of, besides all their cardiac history, is we want to actually tell them it should not be given with food. So we want to give it either 2 hours before or 3 hours after they eat. This basically means it can be protein bound, and we want to try to avoid that. On slide 12, there's a little picture basically saying, what do you look for? So it's in right though. We have that 7-day half-life. So if they miss a dose, the dose is too low, they can see the bradycardia, the lethargy, constipation, excess fatigue, excess sleeping, basically dose is too low, or they've missed a dose and it's now built up. If dose is too high, then we're getting the opposite effect. We're getting the hypothyroidism, the irritability, palpitations, tachycardia, diarrhea, tremors. Basically, things are getting too excitable. Next is going to be hyperthyroidism. So basically, in hyperthyroidism, what do we see? We see high T3, high T4, low TSH. So a lot of things that we got to be careful with this is what we're going to see in the patient. The patient's going to have weight loss, going to have an increased metabolism, diarrhea, tachycardia, tachypnea, potentially irregular heart rhythms, arrhythmias, hypertension. They'll have anxiety, CNS stimulation. They won't be able to sleep. Or it can also have a goiter, which is like the giant swollen thyroid in their neck. One of the common things you see is exophthalmosis. This is the eye bulge. It also can lead to a thyroid storm, basically extremely elevated high T3, T4. First signs of this can be a fever. Basically, it's increased metabolism in your body. When your body has increased metabolism, you make heat. Heat is a fever. I was going to say decreased loss in your level of consciousness, abdominal pain, extremely high hypertension leading to cardiac complications. Can actually eventually see seizure disorders with that as well. So how are we going to treat hyperthyroidism? Well, the thyroid needs iodine to make thyroid hormone. That's why table salt is iodized, because we need it for a thyroid hormone. So we need a certain amount of iodine to properly function. What we can do is we can give them or radioactive iodine. Shrink down the thyroid, shrink down that gorgeous, we can remove it, the thyroidectomy. We can decrease the hormones. We can control the cardiac symptoms with beta blockers. And if everything we does doesn't work, we actually just remove the thyroid itself, which is a thyroidectomy. So drugs for hypothyroidism. So PTU or tapazole. Both of these are going to be for hyperthyroidism. So what do? They're going to prevent the oxidation of the iodine. So we need iodine to make the thyroid hormones. So if we stop the thyroid from taking the iodine, they can't make the hormone. So what do we want to look out for? Well, one is we don't want to give it to pregnant or lactating women because it's also going to affect the thyroid in the fetus or the newborn baby. These medications are going to be short-term or long-term. Hypothyroidism is going to be long-term chronic therapy for the rest of your life. Hyperthyroid can be short-term. It might be short-term for that thyroidectomy, or it could be short-term due to a minor spike in the thyroid hormones. So what are we going to see? So we can see bone marrow suppression. What do we see with bone marrow suppression? We're suppressing the entire bone marrow and all the blood cells. So decreased white blood cells, anemia. Decreased white blood cells, risk for infection. What's the first sign of an infection? Fever. And then decreased platelets. What are you going to see? Increased risk for bleeding. See hepatotoxicity and then renal damage. So how do we monitor for hepatotoxicity? So liver function test, ALT, AST. What do we monitor for renal failure? We want to monitor BUN, creatinine. The other thing is we're treating hyperthyroidism. So what we end up doing, we're going to lower down the thyroid hormones. We're treating hypo, we end up causing hypo. So they're going to be tired, they're going to have decreased energy, they're going to have constipation, bradycardia, bradypnea. Basically everything we're trying to treat with hypothyroidism, we're going to see here by treating hyper. So you also want to monitor the risk for bleeding because of the platelets, fever, their vital signs, make sure they're not getting too low, and also can, with the increased risk for infection, especially nowadays, what are we doing? We're doing social, what's it called? The social distancing, because we're all afraid of the coronavirus. They need to kind of do that too, because that increased risk for getting an infection. They need to make sure they're not around a lot of people. So there's another medication we talk about, and it's Lugol solution. It's a non-radioactive iodine solution. It's also potassium iodine. So what does that mean? So basically, if they're going to go for their thyroidectomy, get their thyroid removed, this is going to be a large dose of iodine, hopefully shrink down the goiter and shrink down their thyroid, so it's easier to remove. We'll do this couple 10 to 14 days before the surgery, kind of decrease thyroid function, and then go from there. So, what do we want to look out for? Well, one, we don't give it again to pregnant women or patients that are lactating, because that can transfer over into the fetus. We want to look for the signs of hypothyroidism because we're slowing down the thyroid. The big one's going to be agranulocytosis, loss of white blood cells. Again, we don't want to give with anticoagulants. The other thing we want to be aware of is, it's not on the slide, but we're giving them potassium iodide. Potassium can potentially lead to hyperkalemia. So we want to monitor the potassium levels. We want to avoid other medications that are going to increase their potassium levels. What are they? ACEs, ARBs, potassium-sparing diuretics. Things you want to be aware of. Next we're going to talk about is osteoporosis. Osteoporosis is basically something has led to a decrease of calcium being stored in our bones. Most common is going to be a lack of vitamin D, lack of poor diet, alcohol, smoking, decreased hormones, especially for postmenopausal women, and also excessive caffeine use can bleach the calcium from your bones. So I think we all kind of know what the side effects of osteoporosis is: weak, brittle bones, bone pain, and of course complications are going to be fractures. So what we need to do is we need to get a diagnostic of how their bones are looking. The best way to do that is a bone density scan or x-rays, CT, potentially even get lab levels. If they think they're calcium's low, let's check it. Let's check their thyroid hormone. Let's check their parathyroid hormone. Let's check their estrogen and their vitamin D. So osteoporosis, whatever the root cause is, it's going to be hard to cure, but we can treat it. We can alleviate the symptoms. Most common thing for all these we're going to do is give them calcium. We're going to give them calcium because the calcium will not be absorbed in the body. We need to give vitamin D. Vitamin D and calcium together. So there's 4 drug classes we're going to go over. SERMs, selective estrogen receptor modulators, bisonophates, calcitonin, and calcium supplements. Something we want to be aware of is we want to, no matter what medications we're giving them, we want to tell them to have dietary changes. They need to increase their dietary intake of calcium and vitamin D. They also need to do lifestyle changes. They need to have low stress, low impact exercise. When you exercise, you cause micro fissures in your bone, which then cause your bone to heal those little fractures and then grow stronger. Walking, jogging, very light weights, things we want to do that kind of help increase that bone growth. So let's talk about some of the medications. So SERMs. First one is Evesta. So basically this is going to be for postmenopausal women because they're having the decreased estrogen. So basically what this does, this is going to basically stimulate, it's like an estrogen agonist. It's going to stimulate the estrogen receptors on the bone, causing an increase in retention of calcium. So by the lack of estrogen in the body, we need to kind of replace it, and we can replace it and then also help stimulate that bone growth. So the most common adverse effects for this are basically the same adverse effects as birth control, because birth control is large doses of estrogen. You basically trick your body to think you're pregnant. So what are the complications of birth control? DVTs, deep vein thrombosis, pulmonary embolism, strokes, MIs, increased risk for clots. Okay, it can be lower extremity edema, leg cramps. So if they have a history of blood clots, breast cancer, stroke, liver disease, smoking, we want to avoid these medications. The other thing is we want to again tell them to increase their calcium and vitamin D intake. Tell them not to smoke, because smoking has increased risk for clots and MI and strokes, and then avoid excessive salt intake. Well, that's because of the edema they have. Increase your salt intake, increase your water retention, increase risk for the edema. So the Evesta is only going to be good for a certain amount of time, and it's only going to be generally for female patients. So the most common one is the bisonophates, Fosamax. They all kind of end in drogenate. So this is the most common one. So basically what this does is it's going to inhibit breakdown of the bone. So it's going to inhibit the osteoclasts, which break down the bone, and promote the osteoblasts, which actually are the cells that grow bone tissue. So it's going to stop destruction of bone and help increase the growth. So that's what we want, right? We have osteoporosis. What do we need to use this? Well, one, we need to have calcium and vitamin D to replace the bone. We also want to be aware of what to look out for. It can lead to acid reflux issues, esophagitis, esophageal ulcers, esophageal erosions, and then so if they have a history of GERD or heartburn, we want to caution its use. We want to tell them to sit up 30 minutes after taking the medication. Anything that causes GERD or reflux problems, NCLEX always says sit up 30 minutes afterwards. After that, you're fine. So you also want to monitor the calcium levels because it can lead to hyperkalemia in the blood, so decreased calcium. And with that decreased calcium, what is happening? So we have decreased ionized calcium in the blood. We don't have enough calcium for our muscles to contract. What's an important muscle? Our heart. So that's going to be important that we're watching. It can lead to constipation, abdominal pain, and then also osteonecrosis. It can actually lead to cellular death of those bones. So you want to also monitor the bone functions themselves, make sure things aren't getting worse. Next we can give them is calcitonin salmon. Basically, calcitonin is the hormone that is used to help stimulate bone growth. So we're giving them basically calcitonin derived from salmon, hence calcitonin salmon, and it can be given with a nasal spray. And so basically, if you're doing nasal spray, you want to make sure you want to go from each nares one to the other. You also want to caution fish allergies because it is derived from fish. You want to monitor their calcium levels. You want to tell them to increase their calcium and vitamin D intake. Last is probably the most one we probably think of the most often with this would be the calcium supplements. They need more calcium, right? So let's replace it. What is the most common calcium supplements? It's probably going to be some sort of acid reflux medication. Calcium carbonate, Tums, calcium citrate, Citracal. All these are going to help supplement their low calcium. So for replacing calcium, what do we need to be aware of? We need to be aware of potentially hypercalcemia. This is only going to be common with IV. So if we take too much calcium into our body, we're going to basically urinate it out. So if we just take it PO, very low risk of having hypercalcemia because we're basically urinate it out. But if we urinate out a lot of calcium, most kidney stones are made of calcium or uric acid. So you want to caution for kidney stones. Tell them to drink a lot of water to help flush out the excess calcium. And because they are antacids, they're going to decrease the stomach acid in your body. Decrease stomach acid, you're going to decrease the breakdown, metabolism, and the absorption of other medications. You want to tell them to take it 1 hour before, 2 hours after other medications so you don't interact with the absorption. And that's pretty much chapter 16.